Well, welcome once again to Calaveras Living. Of course, there are a lot of medical advances, and one of the great ones, I guess, in the last decade or more than that would be in orthopedics, especially in joint replacements. And that's what we're going to talk about today on today's program with Dr. Lisa Siegler. And that, you know, I when I see the spelling of that, I want to kind of put an E in there.
Most people put a Z in there.
Oh, is that
Ziegler?
Is that right? Okay. Well, Dr. Siegler is an orthopedic surgeon at Mark Twain Medical Center, and she's been in this area a relatively short time, but she and her family are really enjoying it, and we're going to talk about orthopedics. And I guess there have been a lot of advances in the last, decade or 2 decades?
Absolutely, especially with the total joint reconstruction, and we're moving more and more to the less invasive surgeries and doing more things through the scope or arthroscopically.
Uh-huh. And what is the most common orthopedic procedure? I mean, is it hips? Is it knees? Is it elbows?
That's one of the things I absolutely love about my profession is we have several common procedures that we do. So probably the most common would be knee arthroscopy or a knee scope to treat things like a meniscal tear or damage to the cartilage of the knee. We're doing shoulder scopes now. So we used to do a lot of open procedures that required patients to spend the night and a lot of pain, a lot of recovery. Now we do all of this through a scope.
Wow. But you have your glasses on and looking everything magnified.
I'm looking at a large monitor.
Okay. Most of the procedures then are, say, repair in nature rather than replacement. Is that right?
Well, when we're doing total joints, that's when you've destroyed your joint, for example, a knee or a hip, and there's nothing left. You've worn it out completely. Then we have to replace it.
Okay. And what's the material they use most commonly in replacements?
It depends on the structure, but usually there's metal for the replacement that goes up against the bone and a polyethylene liner.
Oh, okay. Where is that procured? I mean, how do you know when you order, and it's like ordering a product or something, you want to make sure you're getting the best, I'm sure.
Well, in orthopedics, we have a very strong relationship with the reps, the instrument reps. So there's several different brands, I guess you could call them.
Okay.
And they've gone through many, many years of testing.
When you have a particular replacement, do you yourself personally select what you're going to use?
Yes, of course.
Okay, that's, wow. What's the most challenging of the surgeries you have to do? Oh,
that's a good question, because anytime you find a challenge, then you want to perfect that area. So when I first started doing shoulders arthroscopically, we have many different laboratories that you would go to work on that technique. So
they're located in the West Coast, or?
Oh, they're all over the United States.
All over, okay. Where did you go yourself?
There's different stations in California and in Chicago.
Did you get to be on the West Coast, or did you have to travel for that?
Sometimes traveling and sometimes staying home.
Yeah. And then they have the training would be a number of days or short and then go back?
Sometimes our courses are a week long and sometimes they're just a day. This is all after our residency training, of course, which is 5 years after medical school. So it's 5 years of intensive orthopedic training.
Well, after medical school.
Right.
Yeah.
And our training never ends.
Never training.
Nope.
Okay. Now, you spent part of your time in the Navy doing orthopedics, right?
That's right. The Navy paid for my medical school at USC. And in return, I served with the United States Navy for 4 years, taking care of the active duty servicemen and the retirees. So I got a lot of experience there with the Navy.
So some of these men, or maybe most of them, or women too, they were from injuries or accidents or war or what? All
of the above. So some of our retirees, again, have worn out their joints, their knees and their hips from many, many decades of hard work on the decks. So a lot of knee replacements. And then we have a lot of young, active duty, 20-year-olds who are very active, and they dislocate their shoulders and tear their ACLs. And so there's a lot of what we'd call sports medicine as well.
Oh, well, that's interesting. Sports medicine in itself is interesting.
Oh, absolutely.
But they would injure them sometimes on duty and sometimes off duty, right?
Correct. Usually it was off-duty recreation.
Weekend warrior.
Yes.
Doing too much in a short time. Now, when you start like a shoulder, doing it arthroscopically, does the person then come in and have a personal consultation with you at the start?
That's right. They have to be seen first in the clinic. So usually they get referred from their primary doctor, or they call and make an appointment. And then we get to meet and get a physical exam, and I get their history. And we usually start with x-rays. And then if we think there may be a deep injury, sometimes we need to order an MRI. And that will show us the soft tissue damage. For example, a labral tear or a Bankart tear in the shoulder.
So it's a lot of kind of diagnostic things just at the start.
Beforehand. And then we meet again to talk about treatment options, whether we want to do surgery or physical therapy.
And that's kind of in the patient and you, kind of deciding what seems to be best.
It's a combined effort. That's
Okay.
right.
You ever had a patient like push for the wrong thing that you knew, they're going the wrong way?
Well, both ways. We've had patients push for surgery and we know they're going to get better without it. We have patients who don't want surgery and we know they're eventually going to come back. So we give our recommendations, and I would say for the most part, that's what patients want to hear, is what's our recommendation.
But they actually, if somebody comes into Mark Twain, they come into the clinic. You were telling me before the show, 2 days of clinic and 2 days of surgery,
right.
Generally.
And I have one clinic in Angels Camp and then one clinic in Valley Springs.
Okay. So they get to personally talk to you. You evaluate their
we sit
either
down
MRIs
and talk,
or
and
whatever
then,
it is.
That's right.
Do you have to take CT scans sometimes?
CT scans are more helpful for looking at details of the bone. So occasionally we get a CT scan.
Okay.
Yeah.
Is it true CT scans have some radiation and MRIs don't?
That's right. So the CT scans do have more radiation. We try to limit those and only get them, for example, if we want to see the details of a fracture or broken bone around a joint, for example, and we're trying to decide how much displacement there is to see if we need to fix that with surgery. So it's not often that we would order a CT scan.
Okay. Getting back to the variety of operations where you actually replace something, you've done full shoulder replacements too, or now it's tough?
I've assisted with shoulders. That's on my list of things to do. That you were talking about challenging surgeries. A shoulder replacement, I consider that a challenging surgery. We're still, I would say, advancing in those techniques. So, so I do total knees and total hips replacements.
Total hips. Which is more complex, of the hip or the knee?
The hip replacements are fairly straightforward. The knee replacements, if a person has gone a very long time without surgery and they've really worn out their joint on one side or the other, they may have a deformity that needs to be corrected. So sometimes the total knee replacements can have a little more fine-tuning that needs to be done.
Yeah. I was telling you when we talked on the phone the other day, a friend of mine had his knee replaced, maybe 2.5 months ago or something like that. And he can't, even though he's been pretty good about doing the rehab and the exercises, he can't seem to straighten it out all the way.
Well, I have to tell you, can be a problem. And I always tell patients that 50% of the job, probably the easier part, is what I do in the OR. The hard part is the patient and the rehabilitation that happens afterwards, and that's so very important.
And that, of course, it depends on the health of the person, the age of the person, all that, how long it'll take.
Well, we used to say age, but now we know we have 80-year-olds that need to get back to tennis, so we call it the physiologic age.
Well, actually, we have a friend who's she just turned 90, and a couple of years ago at 88, I mean, she had over a period of a couple of years both hips replaced, and she's doing very well.
Right.
And you know, and I would guess that she doesn't do a lot of exercise.
Those are life-changing surgeries.
Yeah, but she's done very well and gets around and seems to be very good. How do you keep tabs once the patient leaves? Who keeps tabs on them to see that they're doing the proper things for?
Well, we have a lot of follow-up after surgery, and that's very important, so they have regular visits in the clinic.
Oh, so they can, okay.
That's right, and so we see if they have any questions, and we're checking their motion, make sure they're not getting too stiff, and making sure everything's healing properly.
Okay, how do you motivate somebody who's a little lazy?
That's a good question. Usually people are pretty motivated to get better. And I think the best people to do that are the physical therapists, where they really get on them.
Okay. And you're in contact with the physical
That's right.
Wow. The days that you operate most of those 2 days that are generally scheduled for surgery. You're operating most of the day of each of those days?
Tuesdays and Thursdays.
But I mean,
most of the day.
How many operations might you do in one day?
Oh, probably 3 to 4.
3 to 4.
And sometimes there's add-on cases. If somebody comes in with an urgent issue, a fracture, for example, that has to be done, they'll get added on.
How do you keep your concentration for that time? And you're on your feet, right?
It's the best way to stay concentrated is to have something that you really have to focus on.
Well,
so that's why sometimes surgeons have to be reminded to eat, to drink.
Yeah, keep hydrated, huh? Well, that's a challenge. How have you gotten so much experience? You said you were in the Navy for 4 years in USC and all that, but how did you get so much experience at such a young age?
Well, thank you, but I'm not actually that young, but I did get quite a lot of experience.
Well, unless you've had plastic surgery.
No,
no.
Not yet.
No. Okay.
In the Navy, I got a tremendous amount of experience, and that was really a wonderful experience.
Did the Navy have good equipment and good doctors?
The best. Anything that you wanted.
Okay. And of course, USC had some of the best things that you would need. That's an excellent school.
And then we got deployed for the war, and we were in little tents with dirt floors operating on the Marines.
Oh, in what areas? What areas of the country?
Well, we were deployed to Rota, Spain. So, but they were every other day flying the young Marines in from Afghanistan and from Iraq.
How do you keep everything sanitary in those situations?
That's such a good question. Of course, I don't think we really did, and our infection rate was 0 because they're just so healthy, and the tents were new and
young people. Yeah,
young people. It was a dirt floor.
Many women from the war too.
Some women, yes. Oh, yes.
Yeah.
Yep, they're out there too.
What type of injuries would they? I mean, they would have.
These were 80% of the injuries in the war were orthopedic because of our fantastic body armor, Kevlar. So our general surgeons were quite bored, actually. They didn't have a lot to do. Our neurosurgeon didn't have anything to do. It was all extremity injuries. So blast injuries and penetrating injuries, exploding shrapnel.
What was your feeling when you first got into that situation?
I couldn't believe how young those Marines were. They were so young. Very dedicated to what they did, but so young.
Very difficult.
Yes.
Now, we were when we were chatting the other day too, you said you were surprised that, I mean, we all know, and all the people watching out there, they know that many women are going to medical school, but you're surprised that there are not more women going into orthopedics.
I am surprised about that. 51% of the med school classes now are women. And they're going into surgery, and general surgery, and plastic surgery, and cardiovascular surgery. But for some reason, there's still not a lot of women going into orthopedics. We're still about 3 to 5% women, and I just think it's because they don't know how much fun it is. And there's a stereotype.
Doesn't sound like fun with dirt floors.
Oh, well, that was the best, of course. But there's a stereotype that you need to be a big, hulking guy that, you know, blocks the sunlight when you come in through the door. And,
Yeah.
but really, we're using power tools these days. So if you can pull a trigger on the drill, you can do the work in there.
But you have to be very skilled.
You do have to have some strength, and there's a lot of technique and a lot of training involved. But I am surprised there's not more women. That changing slowly, but they're going into other fields.
I mean, 3 to 5% is very low.
It's very low.
When you say that 51% going to med school.
And our academy is looking into that. We don't want to miss recruiting talented people into orthopedics.
Speaking of recruiting, how were you recruited to come here?
Well, they needed an orthopedic surgeon in Calaveras. And so I was recruited, and I met with the hospital administration, and I was impressed with several things. I like the beauty of the area. Of course, right now it's so green and so beautiful, and I have 3 small boys, and we need some runaround room, and this is such a beautiful county for that.
Well, but how, when you say they recruited you, how is that by mail, by email, by phone, how did they, reputation?
I guess I got a notification in the mail and contacted them, and was invited for an interview, and they liked me enough to invite me back for a second interview, and we hit it off, and it seemed like a good fit.
It seems like Mark Twain Medical Center has lately strengthened their staff.
Absolutely,
quite a way.
they've just hired on several new physicians and specialists, so they are growing.
Yeah, they seem to be expanding. I mean, just more services
and quality physicians.
That's what happens. This is way off the subject, but what happens when you're talking about quality, you know, good quality and experienced, dedicated people? What happens when I don't know if it'd be you here or anyone hears of a doctor who's just not doing his or her job? What happens? I mean, they come up before the board, or what happens?
Yes, so there's an internal review process. There would get complaint would be made, or they would be written up for different events, I suppose, and then there's a review process if it becomes an obvious pattern.
Is it a complaint by a patient or a complaint by a staff member?
Well, it could be either.
Could be, okay.
Yeah, fortunately, that doesn't happen very often.
Okay.
But that's how that would go. It would go before a review panel.
Now, speaking of good doctors, too, Dr. Orman recommended that you come on the show here, and we're glad he did.
Yeah.
How did you get acquainted with him? Of course, he does anesthesia.
He does the anesthesia, so he helps keep my patients asleep and comfortable, and then allows me to do my surgery.
How, let's see, on all the type of surgeries that you do, the patients are completely out or just partially?
Most of the time, they're completely out. Every now and then, they'll get a spinal, and so they would be awake, but maybe sedated. Whatever it takes to keep them comfortable during the procedure.
Oh, okay. And you can tell it kind of by the size of the person, or how does an anesthesiologist kind of equate that?
Dr. Orman would be the best person to answer that, but they're looking at many different values. For example, their vital signs while they're asleep, to make sure they're still comfortable, that the blood pressure is not going up, their heart rate's not going up. They can tell these things.
Yes, I know the few procedures I've been in for my back. They're constantly,
constantly
checking,
monitoring everything.
How do you keep your sense of humor?
You have to have a sense of humor. If you lose your sense of humor, well, you've just lost it.
It gets too serious. But
the crew there is at Mark Twain Medical Center in the operating room are so wonderful to work with. I feel so very blessed to have them. That makes or breaks my job right there, is the OR nurses and the OR techs and the OR crew. And there really is a fabulous group there. So,
how many people would normally be in
an OR
yeah.
case? Well, there would be one scrub tech, we would call them, and that's the person who's handing me the instruments that I need. And then there's a circulating room nurse, and sometimes there's a supervising nurse as well.
Okay, so normally 3 besides yourself?
Right, and then the anesthesiologist, of course.
Okay, the 4. Okay. And then, I mean, you're just free to take as long as you want. I mean, you certainly can't hurry those types of things, I wouldn't think.
You do need to be efficient. You don't need to rush, and you don't need to be slow, but you need to be efficient.
Yeah. Well, you learned that in all your training.
Yeah.
What's the most, when you were, in Spain, what was some of the most challenging things, for you personally that you just said, wow,
Again, the trauma was easy, lots of trauma, and that's, almost second nature after a while. So it'd be like a mechanic working on their car underneath the hood. The challenging part was the young Marines were not always mentally prepared to go through what they went through. Yeah. They had all the physical training, but they saw quite a lot, and that takes a while, I would imagine, to recover from.
Oh, yeah.
So we're treating, the whole patient, not just their arm or their leg.
Yes.
And so they went through a lot. And
Did you see some of those young servicemen or servicewomen any time later who had recovered?
Back and say, no, I have not.
Of course, you were over there and they're
right.
spread around.
Our job was to patch them up and send them back, or fix them up and send them home, depending on the severity of their injury.
Did some of them still want to go back?
Oh, they all want to go back, of course. They all want to go back. They're very dedicated.
That's amazing. Now, what haven't we talked about, Doctor, that some of the services that are available in orthopedics at the hospital? Well,
I think a lot of people delay coming in to see a surgeon because they think that if they go in, they're going to get a surgery date, and that there are no other options. So I do want to make that point that if you're having knee pain, hip pain, shoulder pain, to at least come in for an evaluation. And there are several different treatment options that are non-operative. For example, steroid injections and physical therapy and rehabilitation, and there are things that can really help. And sometimes it's a stepwise fashion that we proceed to OR if that's the way we're going.
Okay.
So I see a lot of patients who have waited too long or shouldn't have waited that long. Yeah. And after a knee replacement, after 5-10 years of severe pain and disability, that's the first thing they say to me is, I should have done this a long time ago.
So that was kind of a little fear of surgery.
Oh, sure. And they just learn to deal and accept the chronic pain that they're in, but it affects, they can't play with their grandchildren, they won't decide not to go for a walk, and they're fearful, I think, to come in because it is the unknown, and it is intimidating.
Yeah, I guess it's a challenge, and no two people are alike. I guess some come too soon, some come too late, some people come at the proper time.
Often it's wives will bring their husbands in and say, fix him, he's too grouchy.
And you said you can't fix that.
Well, you can sometimes, because sometimes it's from the chronic pain, absolutely. Yeah. And then after a hip replacement or a knee replacement, which is one of the most successful surgeries out there, the wives will come back and say, thank you for giving me my husband back. And that's probably one of the most rewarding things you can ever hear.
What's the typical amount of or length of time that a knee replacement for, say, a man or woman in their 40s, can they go on for decades, or usually it has to be replaced?
Well, we used to say, we're not doing a total joint on you until you're at least 60, 65 years old. At least that's what we said when I was in residency. You have to wait. Okay. We don't say that anymore. If someone's, usually they are about that age when they start wearing their joint out, that so badly that they need a replacement. However, sometimes people wear it out sooner. They've had trauma, or they've been in a car accident or wreck, and they've damaged their knee, or they've damaged their hip for various other different reasons. And they're in pain, and really that's the indication for getting the surgery done is the pain that's not being effectively treated by any other means.
Okay, but
so then how long it will last depends, kind of like a Goodyear tire. There's so many cycles. It depends on how active you are and how much weight you're carrying around, whether you'll wear that out or not. But 20 years is a good bet.
Is that right, for knees? Shoulders and hips too?
That doesn't mean that at 20 years automatically it will wear out, but that's a good estimate.
Oh, that's a good length of time.
Yeah.
Now, in the remaining time we have, anything else we're missing that people should know, out there if they come out to Mark Twain? They can ask for you, or they can just say they want to talk about a possible evaluation.
Yes, and first, I think the best place to start is in the clinic for an educational sit-down if you have a question about your shoulder pain, your knee pain, wrist pain, hip pain, to come in for an evaluation. If you've had some of these issues going on, especially if it's been 6 months or more.
Sure. And the clinics are where?
There's one in Angels Camp.
The one right in just the one in the shopping center there?
It's on Stanislaus.
Yeah, okay.
And then the other one is in Valley Springs at the specialty care clinic at the Family Medical Clinic.
Okay. So people should come in and even probably come in a little before they think they should, and get an evaluation.
That's always best.
Okay. Now, I know everybody knows the number out at Mark Twain, so that's where they can contact you, and we appreciate you being here.
Thank you so much.
And appreciate Mark Twain for hiring such good new people, too.
Yes, absolutely.
That's great. Well, there goes our half hour.
Okay.
But anything you want to add at all?
I think I can't think of anything else. Just to say that Mark Twain Medical Center is really doing a fantastic job at recruiting excellent new talent. And I know we have a lot of folks in the community who are going outside to other facilities outside the community, and I would just like to stress to those people to give the physicians in town a chance.
Yeah, and come out and see you. Okay.
Yeah.
Well, we thank Dr. Ormond for recommending you. He can get an agent's commission.
Yeah.
Anyway,
I'll let him
Dr. Lisa Siegler, and she's out there taking care of a lot of people and certainly giving proper evaluations. So we'll see you next time on Calaveras Living. Thanks a lot.